of Wangyang Shin. He's the first author and did most of the work, and is he's sorry that he couldn't be here. So first, just to mention, we're going to be talking about respiratory and cardiac fluctuations, and I'm going to focus specifically on measured fluctuations. So the diagram at the bottom of this slide shows the time-synchronized physiologic signals and the MR image. So since physiologic fluctuations don't generate direct, coherent bold fluctuations, physiologic noise modeling is performed in the imaging domain driven by the hemodynamic response. So retro-ICOR is one really common method of regressing measured physiologic signals out of bold data. Retro-ICOR works by defining the phase of the physiologic signals and then models the bold fluctuation that's coherent within the cycled physiologic signal. So the images on the right are from the original Glover paper, and you can see highlighted in the yellow box the frequency power spectrum before retro-ICOR is run, and the arrows point to the frequency components of the cardiac and respiratory signal. And then in the red box, you can see the frequency spectrum after retro-ICOR is run, and you can see that those peaks are gone. So we tried to replicate Glover's work with our own data. So on the right, you can see a figure from the original Glover paper plotting the MR image intensity over the cardiac and respiratory phases. And then on the left is our data. And I should mention that all the data that I'm going to talk about here was acquired at 3T, 31 slices, single band. And I should also mention that the data that you see plotted here, the hemodynamic responses are from the voxels with the highest 1% of F values from the fitting to the retro-ICOR model. So first you can see that the average HRF looks really similar to what Glover originally found, so that's encouraging. The variation is pretty large, and we noticed this kind of unusual banding pattern over the phases as far as the standard deviation is concerned. So in this study, we wanted to investigate the source of that pattern and why there's such a large standard deviation. So this isn't actually investigating the physiologic noise correction itself. It's investigating a property of the modeled cardiac and respiratory hemodynamic response functions. So keep that in mind. Here is the coefficient comparison that we did for the coefficients from retro-ICOR. So the equation at the top describes the first and second order harmonics that are used as regressors. And you can see below the sine and cosine coefficients plotted from a single subject. And again, this is from the top 1% of voxels with the highest F values. So if you look at the first order coefficients, you can see that there's anisotropy, and that the anisotropy is stronger in the respiratory coefficients than in the cardiac coefficients. And here's the same data in 12 subjects. And you can see that it's really consistent. There's this anisotropy, and the anisotropy is stronger in the respiratory coefficients. So what does this mean? The ratio of the alpha and beta coefficients in the sine and cosine equations indicates the constant phase of the signal. So with the directional distribution, like we see in the respiratory signal, that indicates that the phase has a fixed polarity. But when you see a more circular distribution, like you see in the cardiac signal, that indicates that the response function the response functions have different phases, so they're shifted or time delayed. So we wanted to confirm that. So we recalculated the voxel-wise response functions to account for polarity and phase shift. So even though the term correction is used here, this isn't really a correction. It's not like this isn't an image-based correction like something like retro-ICOR. These are just corrections that we did in a voxel-wise manner applied after the physiologic noise correction had already been done. So this is really only for confirmation purposes. This isn't something like a correction that you would apply to your own data. So for the polarity correction, we calculated the voxel-wise phase from the first harmonic of the sine and cosine coefficients, and then we calculated the average phase as the average across the voxels with the top 1% of F values. And then we correlated the two and just corrected the sign of the voxel-wise phase depending on the sign of the correlation. So it's just little, that's what it looked like when we did it. So the phase shift correction was, similar in that we calculated the phase of the voxel-wise phase and then the average HRF across the top 1% of voxels, and then we just subtracted them. So it's just a shift. So let's look at some results. So here, each column corresponds to one of the 12 subjects. So in the first and fourth rows that are labeled as raw, that's the plotted standard deviations of the HRFs from retro-ICOR. So what you're seeing is basically the HRFs just plotted on top of one another. And as we saw previously, you can see that there's a lot of variation and there's this obvious banding pattern. Then in the second and fifth rows, you can see that we applied that's where we applied the polarity correction. The variation is clearly reduced in both the cardiac and respiratory HRFs. So this is especially noticeable in the respiratory HRFs. You can really see that the banding pattern is weakened or even eliminated, and the standard deviation is greatly reduced. So what this is showing is that the correction is kind of lining up the HRFs. They're becoming more similar. And then finally, the third and sixth rows show the phase correction, or show the HRF plots after the phase correction. And so you can see that the respiratory signal, there doesn't really seem to be any sort of consistent decrease in variation. And by the way, this is just, we're just kind of visualizing this, or looking at this qualitatively. But if you look at the cardiac signal, you definitely do see that there is kind of consistent decrease in the standard deviation. So what does this all mean? So these kind of suggest just incidental, or kind of probably the large standard deviation and banding are explained by the polarity and phase shifts. So we saw this reduction in standard deviation with the polarity correction in the respiratory response, and that implies that polarity, a single linear regressor should be good enough, and you can just account for polarity with the sign of the coefficient of the regressor model. But as far as the cardiac response function, because of the phase shift, a single linear regressor might not capture this phase-shifted cardiac noise. And I should specify that this has nothing, retro-ICOR is fine. This is not saying anything bad at all about retro-ICOR. It's really just looking at the properties of the resulting HRFs. So we were thinking about what is the impact of this on physiologic noise correction models. So we just, for our own interest, looked at compared three models. First, we used retro-ICOR, and we used second-order regressors. And then we looked at this model that we called response function. So this model considers polarity. It calculates the response function over phases, and then a slice-wise linear regressor is calculated corresponding to the slice acquisition time. So as you might be thinking to yourself, this isn't really a model that would typically be used, but we're just including it here as a comparison to the third model, which is meant to synthesize a more commonly used method, and that's the response function model with the slice acquisition timing shift. And you sometimes see that the slice acquisition timing correction is applied really, really early. So that's what we did here. We applied that first. And then the response function is calculated over phases, and in volume-wise, linear regressor is calculated over slices. So this would be something like white matter ROI. So here are the results from that. So in this slide, the voxels, the color overlay are the voxels that show the highest relationship to the modeled signal. So red voxels are the best fit to the model. So you can see that in the second row, the response function method with the slice-wise regressor seems to perform fairly similarly to retro-I-core when you're looking at respiratory. There are some regions that are missed in the cardiac modeling, specifically around arterial areas. It's subtle, but it's possible that the use of a single linear regressor doesn't capture all these areas due to the phase shift. In the third row are the results of the time shift, I should say the model that includes the time shift slice acquisition correction. And you can see that it does not perform very well, especially as far as the respiratory noise. So I'm out of time, but anyway, the physiologic noise correction methods that use a single HRF don't adequately model the phase shift. You know, it's subtle, so there may be some trade-off there. The kind of incidental finding, and one that's been reported previously, is that the physiologic noise correction should be applied before the slice acquisition timing correction. This is really just confirmation that the ROI-based signal regressor reflects really limited physiologic fluctuation, particularly in the respiratory signal. And I should say that we didn't look at any low-frequency fluctuations here, but that's something that we're doing right now.
Thank you very much,
Thank
Katherine.
you.